Hello, this is Jeff Swenson. We'd like to provide you with a brief instructional video on the use of a new fenestrated needle for fascial plane approach to peripheral nerves. In this particular talk, we were going to discuss the anatomy of the adductor canal and the saphenous nerve. This needle is manufactured by IMD, whose website and web address can be seen at the top of this image, www.imd-inc.com. And if you would like further information on this needle, you can contact them at that website. Since the majority of nerves in the lower extremity are positioned in a well-defined fascial plane, the design of this needle was centered on being able to deliver local anesthetic into these fascial planes a distance away from the nerve and thus avoid the need to have immediate proximity between the needle tip and the nerve itself. And we'll explain what that means in the subsequent slides. As I mentioned, the design of this needle includes a pencil point, which allows the operator of the needle to have visual and tactile feedback of tissue planes as the needle is advanced. Also, the pencil point of this needle compared to a traditional beveled needle is relatively atraumatic to vessels and nerves. The side fenestrations provide improved distribution of local anesthetic into these major fascial planes where the nerves travel. And the pencil point of the needle without any opening at the end or tip of the needle prevents intraneural or intravascular outflow of local anesthetic from the needle tip. There are three design options available for this needle. It comes in a 1 centimeter fenestrated segment, a 2 centimeter fenestrated segment, which is the needle that we will use in this block today, and the 3 centimeter fenestrated segment. So all three of these variables can be achieved with different needles produced by IMD. There are three main blocks we'd like to talk about today that can be facilitated by the fenestrated needle, namely the femoral block, the sciatic nerve block at the popliteal fossa, and the proximal saphenous adductor canal block. In this brief video today, we're going to focus on the proximal saphenous adductor canal block. If we look at a fresh cadaver dissection, you're looking at the inner aspect of the left thigh. The leg has been removed at the level of the hip. So on the left of the screen is the hip, on the right of the screen is the knee. We see in this image the vastus medialis, all the subcutaneous tissue has been removed. This is the Sartorius muscle. These are the adductor muscles, brevis, longus, and magnus, the semimembranosus, semitendinosus muscles, and the gracilis, which has been reflected in this image. If we go down one more layer and remove the Sartorius, we now have the Sartorius and the gracilis reflected. We see the vastus medialis, the adductor, brevis, longus, and magnus, the semitendinosus, semimembranosus, and the reflected gracilis and Sartorius muscles. Here, the roof of the adductor canal or tissue layer enclosing it has been incised, showing the femoral artery and femoral nerve, the femoral artery being marked by the red arrows. You will see that we still see the vastus medialis, the adductor muscles, and the saphenous nerve at this point crosses over the tendinous insertion of the adductor muscles here and passes distally deep to the pes anserinus. The saphenous nerve will emerge in the lower leg from underneath the pes anserinus to run in the subcutaneous tissue. The popliteal artery becomes the popliteal artery when the femoral artery pierces the adductor canal in the floor of the adductor canal and passes into the popliteal space. Thus it changes from the femoral artery to the popliteal artery. Once again, we have the adductor canal here. This dissection illustrates how many nerves besides just the saphenous nerve are found in the adductor canal. This saphenous nerve passes over the tendinous insertion of the adductor muscles, as we mentioned earlier. But within the adductor canal are a number of nerves. And the interesting thing about these nerves is that they leave the adductor canal and pierce the surrounding fascia to travel in the body of muscles adjacent to the adductor canal. And you can see this in a number of cases here with the suture ties around the various nerves. Generally, when we consider a adductor canal block, we are talking about a block proximal to this blue arrow. If we're talking about a saphenous nerve block only, we're talking about a block distal to this arrow. This is an artist's rendition of the right side of the inner thigh. Or I'm sorry, the inner thigh of the right leg. The muscles that we see here are the Sartorius, vastus medialis, and adductor longus and magnus. Unlike at the level of the inguinal ligament, within the adductor canal, the nerve and arteries and vein are all within the same tissue compartment, whereas at the level of the inguinal ligament, the femoral vein and femoral artery are in a separate fascial plane from the femoral nerve. For this reason, it may be beneficial to block the adductor canal a bit lower where we do not have to worry about encountering the femoral artery. Now what we see here on the right is the position of the transducer on the inner aspect of the right thigh at a level where we see Sartorius, vastus medialis, and the femoral artery here. These are the adductor muscles. If we move the transducer distally on the leg, as shown here, to a position immediately adjacent to the superior pole of the patella, we see that what we are able to visualize on the ultrasound screen changes. Most importantly, at this level, there is not a major vessel, and we see the vastus medialis on the left and the sartorius on the right with this very, very heavy tissue plane in between. So here's vastus medialis, here's sartorius. With this image that we just saw now in cartoon form here, we can see that if the needle passes through this space, there's a chance that if the opening is only at the bevel, we would not get an effective block. However, if we have outflow of local anesthetic for a segment of 2 centimeters at regular intervals, we not only get a lot of drug in the space between the sartorius and the vastus medialis, but we also get drug in the portion of the muscle adjacent to the adductor canal, both in the vastus and the sartorius, which will help us block nerves that have already left the adductor canal more proximally and are traveling in the adjacent muscle. So here is an actual image showing the sartorius, the vastus medialis, and our needle insertion, which will pass through the vastus medialis and across the tissue plane containing the saphenous nerve and some other branches. So here it is passing the connective tissue, and now as the needle injects, we see local anesthetic spreading not only in the tissue plane between the vastus medialis and the sartorius, but in the adjacent muscle bellies adjacent to both of these structures. So this was the egress of our local anesthetic, as opposed to outflow from a single bevel